vaccines. This call is being recorded. If you have any objections, you may disconnect at this time. I will now turn the meeting over to ACCV Vice Chair, Ms. Karen Kane.
Hi. Again, welcome to the ACCV members and the ex officio members. First, I guess we need to take a roll call. So I'm Karen Kane, Vice Chair, parent of a child who's gone through the compensation program. And she was born in '94 and compensated in '98 and died in 2009. And so can we just have all the members say hi? Let me know you're here and your name, please.
Barbara Pahu, Children's Mercy Hospital, I'm here.
And William Spiegel, attorney with the law firm of Rawl and Henderson, here.
And also the ex officio members, you can let us know that you're present as well.
Valerie Marshall, FDA.
David Kim, Office of Infectious Disease and HIV/AIDS Policy in the Office of Assistant Secretary for Health.
Claire Schuster, NIH.
Jonathan Duffy, CDC.
All right. Thank you, everyone. And Karen, you want to proceed to the next agenda item?
Yes, I would like to invite public comments on the agenda. Are there any public comments?
Operator, you can open make the announcement that we're accepting public comments on the agenda.
Sure, thank you. If you'd like to ask a public comment, please press *1 and record your name when prompted.
Can we? Okay, I'm going to guess that there's no public comments.
I'm showing no public comments at this time.
Okay.
Thank you so much.
And Karen, sorry to interrupt, Bill Spiegel here. Is anyone else getting that loud feedback, or is it just me?
On just my voice or everything?
So William,
Yeah.
This is Tamara, and I don't hear any feedback on my end. So maybe. So have you muted your the Adobe Connect? Your speaker on the Adobe Connect?
Yeah, I'm actually only on through my phone.
Oh, okay. Yeah. So no, I'm not getting any feedback, and I don't hear any feedback. So you may want to try and dial back in. For some reason, I don't know.
Let me ride it out. I'll try.
Okay. Okay.
It's just me. That's okay.
Okay. Okay. All right.
Okay.
Sorry, Karen. Okay.
No, that's okay. Does anybody have any comments on the December 2020 meeting?
The meeting minutes, right?
Yes, on the meeting minutes. Can we move forward to approve the minutes? Can somebody approve the minutes?
Make a motion to approve, and then a second.
I motion to approve the minutes. This is Barbara Pahu.
Okay.
And I second the motion, William Spiegel.
Okay. So everybody, you're in favor too, Karen?
Yes.
Okay. So everyone's in favor, and the minutes are approved.
Okay. So now Ms. Tamara Overby will give us a report from the Division of Injury Compensation Programs.
Yes. All right. So Annie, you're going to advance the slides for me, right? Or Amber, one or the other, right?
Yep.
Okay. All right. So so this is Tamara Overby, and I am the Acting Director of the Division of Injury Compensation Programs. And today I'll be providing an update on the Health Resources and Services Administration's Vaccine Injury Compensation Program activities. Also, we'll have our normal update from the Department of Justice, their Vaccine Litigation Office, as well as we will get updates on vaccine activities from the various ex officio members representing the Food and Drug Administration, the Centers for Disease Control and Prevention, the National Institutes of Health, and the Office of Infectious Diseases and HIV/AIDS Policy. Next slide. Regarding the number of claims that have been filed as of March 1st of this year, so far in 2021, we've had about, actually, this slide says we've had 1,426 claims filed, but we've actually really had about 1,500 claims filed to date. This, as far as the trend continues with adults filing, claims being filed on behalf of adults mostly, and children, 54 claims, adults 32, almost 1,400 claims filed so far. And yeah, so you can go to the next slide, Annie. Again, this slide just depicts how the claims that are being filed by adults, which is in the blue, which is the total, and the red line is the number of claims that are filed by adults, and the green line are the number of claims that have been filed by children. And this is showing a trend in the program from 2010 to 2020. Yes. Moving on to the next slide, Annie. This slide shows the trend in the number of petitions that have been filed versus the administrative funding that we've received. So again, the number of claims have increased. However, the amount of funding that the program has received for administrative funding has not kept pace with the increase in claims. And so in 2020, we had 1,191 claims filed. We had a budget of $10.2 million, which is about 11% increase, but the increase still doesn't account for the workload that we have. So we still have a backlog, which I'll talk about in the next slide. Next slide, Annie. So we continue to have a backlog, and we are still have claims from 2020 that we're processing. Oh, actually from 2019. We're almost done with the claims that were filed in 2019, but we still have a few. We still have about 600 claims from 2020 that's still in the backlog. So far in 2021, we have about 712 claims in the backlog for a total of 1,260 claims. And as you can see, we have asterisks here to indicate that of the 1,200 of the claims, of the 1,260 claims that were filed, that have been filed on behalf of adults, 585 of them have not been activated by the Office of Special Masters pre-assignment review because there are not enough medical records to deem them substantially complete. Also, the ones that are here on behalf of children in the backlog, it's the same situation, that they haven't been activated by the PAR because there's not enough medical records for them to be deemed substantially complete. So technically, for children, we don't have a backlog. These are claims that are sitting in the PAR. Next slide, Annie. As far as the amount of money that's been paid so far this fiscal year, for petitioners' awards, we paid out a little over $100 million. And for attorneys' fees and costs, we paid a little over $15 million so far this year. Next slide, Annie. Regarding adjudications this year, so far 283 are compensable, 57 have been dismissed, for a total of 340 adjudications this fiscal year so far. Next slide, Annie. And then this slide actually provides a breakdown of the types of compensation that the program has paid out. So of the 240, 100 of them were concessions, which means that HHS conceded that the vaccine caused the injury. 11 of them were court decisions, and the majority of them have been settlements. And with settlements, it's basically we settle for various reasons. And just because a case was settled doesn't mean that the vaccine caused the injury. As far as, and you can go back for a minute, of the cases that were not compensable, it's been 62 this year for a total of 302. Next slide, Annie. Okay. The trust fund has over $4 billion in it, and continues to receive, excise tax revenue, interest on investments, for a total income of over 113 million. Yes. Next slide, Annie. The trends in the program are ones that I have reported in the past, but I'll go over them again. But 90% of petitions were filed for adults in the last 2 fiscal years. Over 54% of the petitions that have been filed in the last 2 fiscal years have alleged a shoulder injury related to vaccine administration as an injury. 73% of the petitions filed in the last 2 fiscal years allege an injury from the influenza vaccine. And about 60% of the petitions filed are compensated through negotiated settlement. And there is still nearly a 14-month wait for petitions to be reviewed by a physician after the pre-assignment review activation date. So regarding the regulation, the final rule, and this is the final rule that proposed to remove, had basically proposed to remove SERVA and vasovagal syncope in the new vaccines category from the table. The effective date of that final rule has been delayed until April 23rd. And this occurred because with the current administration, and generally whenever a new administration comes in place, they would like rules delayed until they have a time to look over them. So this one has been delayed until April 23rd of 2021. Next slide, Annie. So I also want to remind people that we're always seeking nominations for ACCV members, and this lists the categories of the members that we are always accepting nominations for. So if you know of people, please have them to submit their CVs to Annie at accv@hrsa.gov. And this is also Annie's contact information. And that's the end of my presentation. And are there any questions from the ACCV members for me?
I have, again, a comment or a question, and I know that I sound like a broken record, but there seems to be a consistent backlog on all these claims due to lack of people on the ground to work on them. And again, my question is, what can we do as members of this advisory committee to help hire more people so that these claims are not sitting for a year to be addressed?
So Barbara, you all have done, so you all sending recommendations to the Secretary to recommend that that the program get additional funding resources have been helpful. So you all have done as much as you can do. And yeah, so it's up to, the Congress to allocate money to the program. But you all have done as much as you can do at this point.
I think I tend to get a lot of stuff done where I work by being a squeaky wheel, so I wonder if we just need to keep squeaking, if we need to send another letter.
You can always send another letter. And one thing I'll point out too is that, as ACCV members, you can't lobby Congress. So yes, you all can choose to send another letter to the Secretary. Right now we have an acting secretary. The new secretary hasn't been confirmed by Congress yet. But yes, the ACCV members can choose to do that if they want. Because you all would have said, I'm sorry, go ahead.
Yeah, I was just going to say I think we should.
I'm sorry, Barbara, were you saying something?
Yeah, I was saying I think we should send the letter again.
Okay, because Annie, we sent the letter, the ACCV sent the letter, I just want, as a reminder, we'll look to see, because we sent one we sent a sort of an updated letter in 2020, and I'm just trying to remember whether it was around the September meeting or or after the meeting we had in May. We have to check. But yes, we can resurface that letter and update it and have, and send it to you all to review if you like.
I'm on the same page as Dr. Bahood. I mean, this is Karen, and I feel strongly that, if you look back at the largest year that they had for people claims was 2003, and, this is just getting, this is a huge problem. And I actually have another question about when you said 73% were from the flu vaccine, but that so the injuries from the flu vaccine are categorized differently from the shoulder injury. So if you have a shoulder injury, it's labeled shoulder injury, but the flu means there was some complications from the actual ingredients or just an injury from the vaccine itself, which is not a shoulder injury. Is that correct?
Not quite. I will. Annie, can you go back to the slide on the trends so I can explain it to you? So shoulder injury related to vaccine administration is an injury.
Right.
The influenza vaccine, of course, is a vaccine. So we can report data by the injuries that people allege, and we can also report injuries by the vaccine that they allege caused their injury. So these are just two different data points. So it could be that people who are alleging shoulder injury related to vaccine administration could have received the influenza vaccine or some other type of vaccine, and they're alleging that this is their injury. And on the other side, with influenza vaccine, people, for the data point that's here, about 73% of the petitions filed in the last 2 fiscal years allege an injury from the influenza vaccine. It could be multiple or different types of injuries that they're alleging from the influenza vaccine. So it could be some of the same people that are alleging SERVA are part of this 73% because they received the influenza vaccine. Does that make sense to you, Karen?
Yes, thank you.
Okay. Because the other thing they could be there could be other injuries alleged too from the influenza vaccine. It could be, they allege Guillain-Barré syndrome or some other injury as well.
Okay. Thank you.
Mm-hmm.
I have a couple other questions for you. I think that we've talked about this, but I'm still unclear. So does Section 17 of the NPRM make it so HHS does not have to add the COVID vaccine to the vaccine injury compensation program?
So the COVID vaccine is covered by the countermeasures program because the Public Readiness and Emergency Preparedness Act basically says that it's basically countermeasures to treat a pandemic, epidemic, or emergency threat are to be covered by the countermeasures program. In order for a vaccine to be covered by the National Vaccine Injury Compensation Program, it has to be recommended for routine administration to children or pregnant women by the Centers for Disease Control. That's the first thing that has to happen. The second thing is that an excise tax has to be imposed on it. And then the third thing is that it has to be added to the vaccine injury table. None of that has occurred for a COVID vaccine at this point. So it doesn't meet the legal requirements to be covered by the VICP at this point in time.
Okay. Okay. And then...
So, and then let me... Okay, yes.
Go ahead.
No,
oh, okay. Okay.
Mm-hmm.
And so this is on the NPRM, so I know we're still waiting on that. But so does the synchoscope and the shoulder injury, are they gone for every vaccine at this point once the NPRM is approved? So
right now, so the final rule, the effective date of the final rule has been delayed. So the table that was in place before that final rule was implemented is still the same table. So shoulder injury related to vaccine administration and vasovagal syncope and the new vaccine categories are still on the table.
Okay. And then, if they take this off, will all shoulder injuries be taken off the vaccine injury table?
So with that final rule, the proposal is that shoulder injury related to vaccine administration, vasovagal syncope, and the new vaccines category would be removed from the table. That's what that final rule proposed to do.
Okay. And I don't know if you know or if there's a specific person at HHS who's responsible for reviewing the regulation and deciding whether to move forward on the NPRM. Is it just like a group of people, or is there is there one person, or is it just the secretary who's making this final call?
The secretary is ultimately responsible for making changes to the table. It's ultimately the secretary's responsibility.
And is there someone specifically that's working on that right now? Who's reporting to him, I guess, is it? Or I think it's him, right?
So our HRSA leadership is in communication with the acting secretary.
Okay, and that's just a group of people, or is it a specific, it's just called HRSA leadership? Sorry.
So it could be multiple people because it depends on the role that the person is playing in the sort of process. So I hope so. I'm not sure what are you trying to find out, Karen? That's what so I can answer.
I hear what you're saying. You're saying HRSA leadership, but is that
yes.
a certain person, or is it just a group, or is there like a department called HRSA leadership? Or
no, right now our agency is led by an acting administrator. Her name is Diana Espinoza, and so she communicates with staff downtown. When she communicates with staff in the department that work with the secretary.
Okay. Okay, thank you.
Mm-hmm.
Okay, and I think I had the same question about the backlog also. That was on my list of things to talk about. But I guess I want to group. I totally agree that we should, as the ACCV board, is to look and to help this become an expedient process, the way that the act was written in. And I'm also, because you mentioned, and Barbara mentioned, well, no, she didn't mention that, but anyway, you mentioned about the commissioners. I always feel, and I have had this concern since the first meeting, just that we need to have a board full. Is there any, I know you're doing what you're doing and people are putting their names in. Is there anything else we can do to get the board up to proper capacity at 9 people?
So hopefully by June we will have an additional 4 to 5 people, hopefully. Yes.
Okay, and we don't, yeah, that's just, we get to know when it's approved and done, right?
Yes. And like I said, we continue to accept nominations. So yes, please always send us nominations, because we're always, it's a constant process of us, because how the membership works is that at any point in time 3 members are it should be 3 members are rotating off. So we're constantly having to submit nominations to replace members. So that's why we say we encourage nominations to be sent to us at any time so that we have them ready when members are about to rotate off, so that we can submit nominations and have the secretary consider nominations.
Fantastic, thank you.
And as you know, it's a process that can take a while to occur. So that's why we are constantly saying, please send us nominations.
Thank you. I'm excited to meet our new members.
Hey, Tamara, Bill Spiegel
Yes.
here with one question.
Yes.
And Karen, were you finished? I'm sorry.
Yes, no, I was just going to ask if there was more questions.
Okay, so my only, and again, I am the newcomer to this group. I have a lot to learn. But the notice of this proposed rule change to remove these certain SERVA-related injuries from the compensation table. I know the committee has advocated against that and had people come in and speak to that. I guess my question is, at this point, is there anything else as a committee that can be done? I know we can't lobby to kind of advocate against that.
So I can tell you that the recommendation that the ACCV sent back in May about the NPR, it was an NPRM at the time. Our HRSA leadership is aware of that. That recommendation is also down to the secretary. So those views that are in that letter have been read and they are being considered.
Okay.
And also, the discussions that have occurred, the written comments are being, considered that people had submitted in the public hearing, or the written comments. Those are all being considered in the deliberations about next steps.
Okay, thank you.
And I guess I have another question. Can they actually push that off? I know it's in April, that deadline, but can they push it off if they're not ready at the time deadline comes again?
So I believe that could be an option, but I'm not sure. Those decisions haven't been made at this time.
Okay. Thank you. Does anybody else have any questions? Okay, I think it's okay to move forward. Thank you.
I have a question for Tamara. In one of the slides, the claims for adults, the trend was obviously almost an exponential increase over the past number of years. It appears over the last year or so that perhaps there's a hint that it might be stabilizing. To what do you attribute the increase in the significant increase in adult claims? And if we're talking about SERVA, then I should think that for children, certainly children older than age of 3, when the vaccine is when the vaccine is administered in the arm as opposed to the thigh, that a similar increase could be seen for them, meaning older children and teens, adolescents and teens. So there appears to be some discrepancy there, because if anything, claims for children have actually decreased. I'd like to ask you if you can comment on the discrepancy between the claims for adults and children.
So I really don't have an explanation for the increase. Once we added it, once it was identified as an injury, we've had them file injuries alleging SERVA filed by more adults than we have for kids. And
can I jump in for a sec? Could it be also the fact that now we have more vaccines recommended for adults, and so obviously there's going to be more needle-related injuries and vaccine injuries if more vaccines are being recommended for adults?
That could be it too, because there became that sort of universal recommendation back in like mid-2000s for adults, and we added it to the vaccine injury table back then, and then so we started to see some increase back during increase in claims when we added flu, but but also when we basically added shoulder injury related to vaccine administration is when we saw the dramatic increase in claims from adults and specifically alleging that injury. So, yeah.
Yeah, and also we have now Zostavax. So there's a whole bunch of other vaccines and the pneumococcal vaccine. So the adult schedule has been increasing.
Right, but we don't cover those. So we don't cover Zostavax, and we don't cover the two pneumococcal polysaccharides.
So,
we don't cover that.
Pardon the ignorance. Even if it's not covered, can they still submit a claim and then be denied? Is what I'm asking.
So they can file a claim, but we wouldn't consider them in our overall data because basically it's not because it wouldn't be a claim that we cover.
I see. So even if somebody submits a claim for a vaccine that's not covered, that would not be a number you present to us then?
No, because it's not a covered vaccine. Exactly right. We would present data for vaccines that we cover.
Got it. Thank you. That's helpful. I missed that somehow. Or forgot about it.
As a follow-up, I wonder if this is something that that the Vaccine Safety Office at CDC might be interested in doing some additional analyses to determine why is it that the adult claims are going up, and perhaps with more in-depth analyses can come up with recommendations as to how that upward trend can be addressed, meaning lower the possible injury, certainly injury claims, and also injuries in general.
And there has been some work done by CDC, Dr. Kim, and they've reported on it in this meeting. And I don't know, Jonathan, do you have, or can you address some of the work that CDC has done in this area? I know they sort of looked at it, looking at VAERS data, I believe.
I can give you a quick just summary from what I remember you guys presented, and this is what we know is, obviously with more vaccines being administered to adults, more injuries can happen. And part of the problem, as you know, with SERVA is vaccine administration technique. So it's not always just the vaccine per se, but the injection method. And traditionally, vaccines are given more often to children than they are to adults. So adults are really just, I don't know how else to say it, learning how to give vaccines compared to what pediatricians have done for a very long time. So until vaccination in adults becomes more, I think we're going to continue seeing this. So part of the big push that we've seen on the ground is technique administration and how to do vaccines adequately. And I think the second thing that we can discuss here briefly is even though the cases have gone up, if you think about, I don't know if it would be helpful to put the denominator data one day, but how many vaccines have been administered to adults overall and how many times we have, even though the number looks big because it's 1,000 something, proportionally speaking to the number of vaccines that are administered, it's very, very low.
That's true. That is true. So it is, if you look at the data on vaccines, like influenza vaccines administered, it is the injuries are a small proportion, a really small proportion of that. And the other thing, too, I'll mention to Dr. Kim, too, is just because we compensate doesn't mean that the vaccine caused the injury. So that's the other thing I'll point out, too, is that remember this program is not purely medical. It's legal. It's a legal program. And so it's basically sometimes we compensate because it's just cheaper for it makes for a better use of resources to settle something rather than litigate it. Things are compensated for different reasons or settled for different reasons. So it's not always that the vaccine actually caused the injury. So that's the one thing I'll point out about the vaccine program too. It's a legal program.
I understand that it's a program that does not distinguish causation. So I appreciate the response. Thank you.
So we do look at causation, but ultimately the court decides. So HHS, we make medical recommendations, but ultimately the court decides. And so that's where it's more legal because the court makes a decision, and so it's not based solely on science. It's a lot of times they're legal decisions that are made.
I understand. Thank you.
Mm-hmm.
This is Karen. I just want to make a statement from a parent regarding the cases for children that are going down. I just have to say, while autism rates are skyrocketing in children, if you have autism, a lawyer for the Vaccine Injury Compensation Program will not take your case because children with autism are not compensated by this program. And so even though we have tons of families and parents are saying that they have an injury and that led to autism, all of those parents are being disregarded, and it's definitely my opinion that parents are having a harder time getting legal representatives to take their case because it's becoming, I think that the Act now has made it very, very difficult for families to qualify to get compensated for the Vaccine Injury Compensation Program, and that's what I'm hearing. And, with autism rates just skyrocketing and we're not looking at it, and families, even if they have other things that could be part of a vaccine injury, no attorney would even take their case because they know it won't get compensated. So I just wanted to make that statement.
So, Karen, in response to that, I'll say the science doesn't show that vaccines cause autism. So that's why they're not being compensated in the program. And I hear you, but I just need to say that, yes.
Okay.
And yeah. Mm-hmm.
Well, some of the vaccine inserts do state that it causes autism, but yeah, I'm not going to, I just want to make that statement. I know exactly the feelings on this, but, I'm here representing as parents, and
yes.
so I also, I'm just speaking for all the families out there.
Mm-hmm.
So I think I can jump in here and just say briefly, I know that autism rates are skyrocketing. That is absolutely true, Karen, but they are skyrocketing among vaccinated and unvaccinated kids equally. So there is people that are looking at this data and monitoring closely. So I agree with you. Their rates are going up. But this is where causality really does matter, and I think that's what you were talking about earlier. If you go in to get a vaccine and you get out of the clinic and you slip and fall down, it is temporarily related to the vaccine, but it doesn't mean that it was caused by it. So we know that autism is increasing. We're getting better at detecting it, but it just doesn't mean that it's caused by the vaccines. That's why I think that's what you were trying to allude to, right, Tamara? So
yes. Mm-hmm.
Well, and I just want to state that Dr. Paul Thomas just did a study stating, this is why that conversation that we'll be having in June is so important, to look at the vaxxed, unvaxxed. And so Dr. Paul Thomas just came out with a study, and he's a Portland doctor, and it takes, there's actually a lot of studies that are out there, and he actually had his license suspended just days after he put out this study, which, showed that children who aren't vaccinated are healthier. So that's something that I really want to talk about in June, and that's why I've been wanting to use the vaccine safety data link to look at the vaxxed, unvaxxed, because I think this is a very important question to have. When we're talking about, this program was originated for children, and now we're talking that it's, mostly adults, and yet, so why is that? And I think it's a super important question to look at, why are adults getting injured more? But I think also, we're saying that children aren't getting injured, which is shocking, because when this program came out, there were, I think, 12 vaccines on the schedule, and now there's 69. And there's a large group of people that would say that they cannot even enter the program or find an attorney because their injuries, the attorney knows that they're not going to win in court, because we basically can't really talk about autism and vaccines. I mean, that's just taboo. But then, and then there's all those attorneys that are knowing that the table injury is there for the adults, and so though, obviously they're going to be happy to take on an easy case. So I think this is it's a huge concern, and I think it's a very valid question for the ACCV commissioners to really talk about and look at both the adults and the children, and I think it's very important that we do use the vaccine safety data link to look at the vaxxed, unvaxxed, so we can answer this question. I mean, this is
again,
you know, I
we
don't,
are looking at that information, and I want to just reaffirm you that the reason why most of us go into medicine is precisely because we're trying to keep children safe. So it's not surprising to me that vaccines are not causing injuries, because if we know that a vaccine causes an injury, we remove it from the schedule, just like what happened with rotavirus vaccine or with the influenza vaccine. So it is not surprising that there's not more injuries in children. On the contrary, if there were a lot of injuries in children and we kept the vaccine out there, we would be being negligent. And most of us actually want children to be happy and healthy, not trying to injure them. So it is reassuring that the data shows what we have been preaching, that vaccines are safe, and that there are more injuries in adults, because most of these injuries are precisely SIRVA. And that's why I think, and I don't understand this very well, so don't quote me here, but I think that's why they're trying to remove SIRVA from the program, precisely because of what you just said. This program was originally intended to protect children, and now because most of the injuries are happening due to mechanistic issues with injections, that's why they're trying to remove SIRVA. Now, I agree with all of you. We've talked about this before. I think if it's a injury that results due to an injection, it should still be compensated, but I think the reason why they're trying to remove it is exactly what you just said, which I had not thought about until you said it, Karen. The spirit was to protect children, and now most of those funds are going to look at injuries from adults. But I just wanted to say it. It is reassuring to see there's no injuries in children, because if we did see them, Karen, we would be doing something about it to prevent injuries in children.
So if we want to stay on schedule, we probably should move to Heather's presentation. Oh.
Yes, okay.
Okay.
Thank you, Ms. Overby. Okay. So now we're going to receive a report from Ms. Heather Perlman, Acting Deputy Director, Torts Branch, DOJ, from the Department of Justice.
Good morning, everyone. I am Heather Perlman, as it was just said. I am the Acting Deputy Director in the Office of Vaccine Litigation. The statistics I'm about to give you are from the reporting period of November 16th, 2020 to February 15th, 2021. Please keep in mind that that reporting period is different than what you heard from Tamara for DICP, which is why some of the numbers are different. During that reporting period, the total number of petitions filed in the Court of Federal Claims was 1,249. Of those, 1,216 are adults and 33 are minors. During the reporting period, there were 201 petitions that were adjudicated. Of the 201, 157 were compensated. 73 of the 157 were cases that were conceded by HHS, while 84 were cases that were not conceded. All but 2 were decided by adopting a negotiated settlement. And 44 cases were not compensated, and they were. Also, there were 6 cases, petitions that were voluntarily withdrawn during the reporting period. During the reporting period, there was some activity at the appellate level at the United States Court of Appeals for the Federal Circuit. There were 4 cases that were decided. They were all appeals by petitioner. 2 were affirmed, 1 case was withdrawn, and 1 case was vacated and remanded back to the special master for additional proceedings. There are also 3 appeals pending at the circuit that were filed by petitioners. They all involve entitlement issues. There is 1 appeal pending at the federal circuit that has been filed by the respondent. At the U.S. Court of Federal Claims, there were 8 cases that were decided. They were all appeals by petitioner, and 7 of the 8 were affirmed. 1 was remanded back to the special master. There are no appeals by respondent, or no decided cases by respondent at the Court of Federal Claims. Pending, there are 8 cases at the Court of Federal Claims. A lot of them are new. You will see them in yellow. There are no appeals by respondent pending at the Court of We have 3 oral arguments that are scheduled, 2 at the Federal Circuit in April and 1 at the Court of Federal Claims. During the reporting period, we completed 82 settlements. The fastest one was within 10 months of filing, and the longest one was slightly over 6 years. And you can see over the following pages the vaccines and the alleged injuries that these settlements involved. And that is my presentation. I'm happy to answer any questions.
This is Karen. I have a couple of questions. I think I actually just have one not very long question, but one question. So on your charts, they give, you have the cases don't really have case numbers, and we've talked about this, I think, twice before. So it says there's EJ versus HHS, but can we get the citation number? Because I know it's been said that your attorney, you can look at the number and you can get it, but for somebody like me and Dr. Pahud, we're not attorneys, and I would like to basically better educate myself on what's going on, and I was just wondering if you could provide the citation number so we could look those cases up.
So Karen, it probably is actually easier for you to look it up the way we have it. When we report these cases, because they are so close in time to my giving this presentation, a lot of them don't have case citations assigned to them. We have purposely identified the case names as they appear on either the Court of Federal Claims website or the Court of Appeals for the Federal Circuit. So if you type in the search engine on either of those websites with the name, you will be able to see those decisions.
The name here says E.J.
Yes. If you type that in under vaccine published decisions, you will see that. We have tested it.
Okay. And that website's on your presentation?
I don't know that it is. It's the U.S. Court of Federal Claims. If you Google that, I'm sure it will come up.
And then vaccine published decisions?
Yeah, you'll see a section, I believe it's called opinions, opinions and orders, and you can search down. You can do it by vaccine because the Court of Federal Claims hears issues beyond just the vaccine program. So you can narrow it down. You can do search terms.
Okay, thank you. I will try that. Thank you. Does anybody else have any questions for Ms. Perlman? Okay, then we will move forward. I'd like to introduce Dr. Jonathan Duffy from the CDC. He will be giving us an update on the Immunization Safety Office and Centers for Disease Control and Prevention vaccine activities. Welcome, Dr. Duffy.
Thank you. Are you going to control the slides?
I can, or I can give you control, whatever you're comfortable with.
Okay, I guess, well, you can give me control. Yeah.
Okay. Okay, you should be good now.
Okay, yeah. So I just want to first, for the first section of the update is just to highlight recent publications from our Immunization Safety Office. So first is Meningococcal Vaccination, and these are recommendations from the Advisory Committee on Immunization Practices. It was published a few months ago. This is a report that just summarizes and compiles all previous recommendations and updates that document. It also includes new information about booster doses for meningococcal group B vaccines for persons who are at increased risk for serogroup B meningococcal disease. And this also includes summaries of safety information for the various meningococcal vaccines. This next report is a publication on safety surveillance for the bivalent meningococcal group B vaccine. This is a summary of data from the Vaccine Adverse Event Reporting System from the time that vaccine was licensed through 2018. This basically just summarized the findings, the reports to VAERS, and there were no new safety issues identified for that vaccine. Third publication, there's a safety profile of rotavirus vaccines among individuals aged 8 months or older. Again, this is a summary of reports to VAERS. So as a reminder, rotavirus vaccines are recommended to be given to children less than 8 months of age. So this was essentially looking at what adverse events were reported for people who did not follow that recommendation. And no particular concerns identified, but just report reiterated that people should try and follow the ACIP recommendations for the age-appropriate vaccination. Next report is this is a vaccine safety data link paper describing basically methods development for developing algorithms for identifying major structural birth defects using automated electronic healthcare data. So this is, again, just a methods paper to use ICD codes for identifying these outcomes for future vaccine safety research studies. And it was noted that this work was done for the Vaccine Safety Data Link project, but could be applied to other healthcare data sources as well. So in this next section, I just want to provide some updates that have been going on with the Advisory Committee on Immunization Practices. So there was a regular meeting in February that covered several different topics. I'll just mention each of them briefly. Rabies vaccine was discussed, and there was a vote taken on pre-exposure prophylaxis recommendations. And so this was essentially reevaluating new evidence for the optimal number of doses. So this was actually reducing the number of doses recommended from 3 to 2 for adults who are at continued risk for rabies exposure, such as veterinarians and other people that work with animals. There's also discussion of dengue vaccine. So this has, again, been an ongoing topic of conversation to consider development of recommendations for the dengue vaccine that's been approved in the United States in 2019. And so the work group continues to finalize their evidence review and formulate recommendations with a vote planned to occur in June 2021. There's discussion of a tick-borne encephalitis vaccine that manufactured by Pfizer, and they've submitted a biologics license application to the FDA. So in preparation for the potential licensure of this vaccine, ACIP is reviewing the evidence for its potential use, essentially in people who would be traveling to areas where tick-borne encephalitis is endemic, which is not in the United States. So they're going to, if that vaccine is licensed, they would consider appropriate recommendations for it. There was discussion of Ebola vaccine. So in January, there was a report published from the ACIP on recommendations for use of Ebola vaccine. In addition, it was noted that there's been 2 new Ebola outbreaks identified in February in Africa. And then the ACIP also is discussing 2 additional U.S. populations who have potential occupational exposure to Ebola virus, and those would be healthcare personnel who work at designated Ebola treatment centers in the United States and individuals who work in laboratories that support the laboratory research network. So that's an ongoing discussion on recommendations for those occupational risk groups. There's also discussion of hepatitis vaccines. The policy question being considered is whether there should be a recommendation for all unvaccinated adults to receive hepatitis B vaccination. An alternative to this would be to recommend hepatitis B vaccination for any adults under age 59. So it's, again, a continuing review of evidence and discussion with further presentations planned in June and a vote potentially to be taken on recommendations in October of this year. There was discussion of pneumococcal vaccines. So again, there's 2 new pneumococcal vaccine candidates that have applications submitted to FDA. So again, in preparation for potential licensure of those vaccines, ACIP is discussing evidence for recommendations for their use in adults. And if those vaccines are licensed, that could be voted on later in 2021. And then, as noted here at the bottom, licensure for children for these new pneumococcal vaccines isn't anticipated until 2022 or later. So that discussion would not occur until a later date. Zoster vaccines were discussed. This is regarding the recombinant zoster vaccine, which is recommended for adults 50 years and older. It was noted that since this vaccine was licensed in late 2017, there's been 41 million doses distributed in the United States as of the end of last year. So in this session, there was a review of the potential risk of Guillain-Barré syndrome following this vaccine. There was a formal risk-benefit analysis presented looking at the risk of Guillain-Barré syndrome versus the benefits of the vaccine to prevent herpes zoster infection. And there was also a discussion of new additional recommendations for potential use of this vaccine to be recommended for immunocompromised adults who may be younger than 50 years old. There was a discussion of influenza vaccines. It was noted that influenza activity in the 2020-21 season is very low compared to recent seasons. The cumulative hospitalization rate was the lowest since 2005. There were over 190 million doses of seasonal influenza vaccine distributed in the United States as of February. And ongoing work on influenza topic as ACIP is conducting a systematic review to assess the relative benefits and harms of different types of influenza vaccine that are available for older adults. And this will be a topic for further presentation and discussion later in 2021.
Quick question. Is it okay if I
Yes.
interrupt now until the end?
Go ahead.
It says cumulative hospitalization rate lowest since 2005, so silly question, but were we monitoring influenza hospitalization rates prior to 2005?
Yes, the CDC has been conducting influenza surveillance for a long time. I think what I've seen is data since 2000 is available online, and I think data goes back decades before that. So I'm not completely familiar with all the data, but it's been under annual surveillance for many years.
I didn't know when we started. That's all. Thank you.
Sure. Let's see. Oh, so cholera vaccine was discussed. And so the policy topic under consideration by ACIP is whether cholera vaccine recommendations should be extended to include children and adolescents 2 to 17 years old. Current recommendations are only for adults. And again, this is considered a travel vaccine for people traveling to areas where cholera may be active or outbreaks are occurring. So again, there'll be further discussion and a vote planned on this later in the year. And then final topic at this February meeting was for the orthopoxvirus vaccine. So that orthopoxvirus includes smallpox, cowpox, and other pox viruses. And so this is a continuing discussion of recommendations for the JYNNEOS vaccine, which was approved in 2019. And then the question or the thing being considered is whether recommendations to use this vaccine for persons with occupational exposure, such as laboratorians. And so again, this is a topic of ongoing discussion, and a vote will occur later this year. So in this next section, I just want to provide some information and updates specific to COVID-19 vaccines. There's been a lot of work and discussion on this area separate. So ACIP has held additional emergency meetings, 2 in December, 1 in January, and 1 just earlier this week, as recently as Monday. So just to summarize, so as of this week, ACIP has recommended the use of 3 different COVID-19 vaccines. Those are the ones manufactured by Pfizer and Moderna, and then the Janssen vaccine, which was just recommended on February 28th. And those details of those recommendations are available online, the website shown. So ACIP has also issued interim recommendations for allocation of COVID-19, to address prioritization of who should receive this vaccine while supplies are limited, or in which time periods in which demand exceeds supply. So just to summarize or remind people that back on December 1st, the ACIP recommended that healthcare personnel and long-term care facility residents be offered the vaccine first. And then later in December, there was additional information provided that Phase 1B would be persons aged greater than 75 years and non-healthcare frontline essential workers. And then Phase 1C would be people ages 65 to 74 and younger adults with high-risk medical conditions. And so just a reminder, these are guidelines intended for federal, state, and local jurisdictions, but ultimate decisions are made at those local levels. Other topics presented or discussed related to COVID were implementation considerations, clinical considerations, and there are several informational updates on the AstraZeneca vaccine candidate, future pediatric clinical trials, updates on COVID vaccine safety, vaccine effectiveness plans, and at this last meeting, information on emerging SARS-CoV-2 variant strains. So just in this last portion, I would just like to provide some more details about the vaccine safety aspect of things. So these slides were presented at the ACIP meeting on Monday, and then there's more information available, and if people want to look back at that recorded presentation. So I'm just going to hit a few highlights here of the various systems that CDC is using to collect information on COVID vaccine safety. So first is Vsaf, which is the smartphone-based active safety monitoring system that was created specifically for the COVID response. And so this is a voluntary opt-in system in which people can report their health experiences following vaccination. And so here's just a very high-level summary of the data as of February 16th. So as of that date, more than 55 million doses of the 2 COVID vaccines approved by that time had been administered, and slightly less than 4 million people had enrolled in the Vsaf system. And of note, more than 30,000 of these people were represented pregnant women. And there was a MMWR report published with initial findings from the Vsaf data showing that the types of adverse reactions that people were reporting were similar following dose 1 for the 2 vaccines, that rates of reactions were somewhat higher for dose 2 for the Pfizer vaccine, and there was limited information available on dose 2 of the Maternal vaccine at that time. But these findings are consistent with the pre-approval clinical trials. So I just want to mention VAERS is the nation's early warning system for vaccine safety. And again, these are voluntary reports that are submitted by individuals, whether they be persons who are vaccinated or healthcare providers. So again, as of mid-February, VAERS had received more than 100,000 reports for the 2 COVID vaccines. More than 90% of those were considered non-serious, which is similar to what VAERS has seen for other types of vaccines in the past. And so this slide just shows the most commonly reported adverse events following the COVID vaccines. And again, it's things like headache, fatigue, dizziness, fever, things that were also observed in the clinical trials. One new finding that had been noted after the rollout of the vaccines was that there were some people reporting anaphylaxis or severe allergic reactions following the COVID vaccines. So this slide here is just showing that the data in VAERS is estimating that the number of people who experience these anaphylactic reactions are less than 5 per million doses administered, and so that's slightly higher than has been observed with some other vaccines in the past, but is still considered a rare event. And note many of these people who experience anaphylaxis have had histories of allergic reaction prior to vaccination. So based on this information, CDC has issued additional clinical guidance on attempting to provide information on precautions for people with history of allergic reactions and clinical guidance on how to handle treating anaphylaxis in vaccination clinic settings. So our third surveillance system, Vaccine Safety Data Link, which is again our system based on healthcare organization populations with over 12 million people enrolled, is also collecting data on vaccine safety. So you can see in this slide there's data accruing for people vaccinated with both of the mRNA vaccines with over 800,000 doses as of a few weeks ago. And so VSD is conducting various analyses for pre-specified outcomes. So at this point in time, looking at certain adverse events of special interest and doing several different analyses, including comparison of people who have been vaccinated with COVID vaccines to people who are unvaccinated and who have not received the COVID vaccine, and also comparing to the experience of people who received other types of vaccines. So just very high-level summary shown in this table that this shows the 21 adverse events of interest that VSD is currently monitoring. That shows the comparison to people who are unvaccinated. That's people who have not received the COVID vaccine. And it just shows that the number of these adverse events that are occurring are very similar in the people who have received the vaccine to those who haven't. So, this does not suggest any association with these adverse events in these vaccines to date. This next slide just shows the second analysis I mentioned, sequential vaccinated concurrent comparator. And so again, the findings are quite similar, that these are mostly uncommon adverse events, and there's been no indication of any statistical evidence that there's an imbalance between the two groups. And so, this surveillance will continue. So our last system that I want to mention is the Clinical Immunization Safety Assessment Project, which is not a surveillance system, but is a network of medical research centers that provide expert consultation on vaccine safety issues. And so one role of CISA in the COVID response is to provide consultation for U.S. healthcare providers and health departments for complex vaccine safety questions related to the COVID vaccines. And this includes getting expert input from physicians and scientists from various specialty areas. And so, again, as of sort of mid-February, CISA responded to 331 clinical inquiries or consultations related to COVID vaccines from all over the nation. And about a third of these inquiries related to anaphylaxis or allergic reactions. And so CISA is continuing to coordinate with other agencies, including FDA and NIH, on doing additional study and more about what may be the cause or risk factors for these allergic reactions following COVID vaccines. And then here, maternal vaccine safety has been of interest for the COVID vaccines. Pregnant women were not specifically included in clinical trials, so there is limited information on that. So, this post-authorization safety monitoring period will be important for learning about the safety of these vaccines in pregnant women. And so it's just notes here that, Vsaf, as I mentioned earlier, is actually identified, women who have identified themselves as pregnant, and there'll be additional follow-up to learn more about their experiences following vaccination. Bears has also identified reports among pregnant women, but has not, seen any adverse events that would either be unexpected for the vaccine or any rates of adverse events that would be unexpected based on chance alone in unvaccinated individuals so far. So just to summarize, so again, as of mid-February, there was over 55 million COVID vaccine doses administered. As of yesterday, that's up to over 80 million. So far, the safety profiles we've seen for the mRNA vaccines in Vsaf and Bears are consistent with what we've seen in the clinical trials. Anaphylaxis was a new issue that was identified following the rollout of the vaccination programs, but there's been no other serious safety signals seen to date other than the anaphylaxis. And again, BSD has not seen any signals either, but is continuing to monitor, and work is ongoing for all these systems. And then I just wanted to mention here that there's already been some publications with additional information that was presented here. You can see these are several publications in the WR and then one on anaphylaxis in the Journal of the American Medical Association. So that concludes my presentation. I'm happy to take any questions.
I have
Thank you.
a question and a comment, if that's all right.
Yes, please.
Karen, he displayed a graph that I think is exactly what we were talking about earlier, where he was comparing, if you can go back to the rate of adverse events in people vaccinated versus those not vaccinated, that one. And you can see there, for example, appendicitis, 31 in people that were vaccinated versus 23 adjusted, expected, et cetera, risk interval, immune thrombocytopenia, 1-1, Kawasaki, 0-0. So these are the analyses that are usually always happening in the background to make sure that, again, people that are vaccinated still live in planet Earth and, stuff still happens to them, strokes, cancers, et cetera, falls, and that obviously if you get a vaccine, it's very easy to assume that the vaccine caused it because it's temporally related in time. But we do these types of data in the background by making sure that the stuff that happens to people that are vaccinated is happening at the same rate in people that are not vaccinated. So I just wanted to point at this slide. Number two, if you don't mind, I have a quick question/comment. I actually did Vsaf myself, and I noticed an error, and I tried to get feedback, and I couldn't find anybody to give it to. It asked me for when the date of my second dose was, and I entered it, and by mistake, it entered February instead of January. And it's wrong, and I can't go back and change the date. Like once you put it in, if it's wrong, there's no going back to edit. So I just thought I'd give you that feedback and pass it on because I'm sure it hasn't just happened to me.
Okay, thank you. I'd be happy to pass that along to the people working on that system.
And I'd like to have maybe some questions and some statements, and thank you, Barbara, about that. So this report that Barbara was talking about, is that from theirs?
No.
this preliminary, the
No, VAERS is a passive reporting system, so you can't do background rates with VAERS. These are usually done through VSD, but I'm going to let the presenter answer that for you.
Okay, see, it's vaccine safety data link, the rapid cycle. Okay, yeah, so I hear what you're saying. Because we know that only the Harvard Pilgrim study kind of just proved that VAERS is getting less than 1% of the
Yeah,
reported.
VAERS is not a reliable way to get safety data. It's a good signal. So it's kind of like somebody crying wolf. So if somebody cries wolf, you can pay attention and then do your rapid cycle analysis and actual data. So there's systems like, for example, I'm just going to give you one example, but of course there's others. Kaiser Permanente is a healthcare system that monitors healthcare data for their patients, and they capture everything. Like, for example, for me here at Children's Mercy, I may see a kid in the hospital, but their pediatrician may be somewhere else. And they may go see an emergency room doctor somewhere else. So I can't really keep track of that kid electronically speaking everywhere, right? Because they may show up in 3 different systems. Does that make sense? But if you're in Kaiser,
Yeah, go ahead.
yeah, it gets captured everywhere. So these are the places where they can do that type of data, where they can compare people that were vaccinated to people that were not, because they're able to monitor everything that happens to these people. But it is, as you can imagine, Karen, really tricky to do it with the entire population, because most of us, I'm sure you and me, same, we seek care all over the place. So it's hard to, monitor everything that we do.
Well, that brings up a lot of comments. And I have to say, as a parent, it's to say that VAERS is crying wolf is like super offensive. I'm sorry, but I have to say that, because VAERS is we call it the passive program. It seems like HHS use it when it behooves them, and then they don't when it's not. So actually, that's what the parents are given to report. So VAERS is actually really important, and it shouldn't be a cry wolf, looked at like that, or a passive. It should be something that's mandatory, and it should be, that's, really our job, because parents need to have a place to report their vaccine injuries, and they're told to report it to VAERS. And so on that note, I wanted to say a couple things. So I'll start with, there was a discussion just that the flu had been down since, I think, 2005 or something, but it seems to me, just as a logical parent, not a scientist or a doctor, that COVID kind of took the flu so far in the last year, and obviously I could be wrong, but it seems to be something that, all the other illnesses have went away because COVID has taken over all of that. But so I wanted to make that point. I also wanted to make the point of the, let's see, and I heard that VAERS went down just like a couple weeks ago, so I don't know if there's any explanation on why VAERS actually went down. Was that because of the numerous reports? And then again, stating that the Harvard Pilgrim study says that only 1%, less than 1% of the people's injuries are reported to VAERS. And again, Barbara, what you were saying, I think it's very complicated when we're giving the COVID vaccine, and so we're, for the first responders, let's just talk about a fire department, a clinic or someone pulls up and they vaccinate all the first responders of this particular fire department. So that means their medical doctor wouldn't have that information in the vaccine safety data link, because it's not given by the doctor. And it's, I don't know, when we're doing these mobile units or, driving by and getting the COVID vaccine, is that going into the vaccine safety data link? I guess that's my question.
No, that's what I was trying to explain, Karen, and I didn't mean to offend in any way. What I was trying to say is we understand each system has its pros and its cons, and VAERS is very useful as a warning system. That's what I should have called it. But it's not like you said it, a reliable system. You said it, and it's true, because it's not pulling data from hospital systems or from, medical records. It's reportable by people. And so that, as you know, is biased, and it could be incomplete. And that, like you said, not everybody reports to VAERS. Versus a system that is pulling data automatically from a medical record system is reliable, because you don't have to wait for people to report. You just go and look. And so VSD does not capture every single human being on the United States. It's a very limited system of certain health plans. And so it captures about, and somebody on the call who knows this better, 3 to 5% of the population, not everybody. But it is a very thorough system in detecting these things based on how it's built. And so we wish, Karen, we had a system that could monitor everybody in the United States. But even if we built it, you know there would be people complaining about their liberties and being monitored. So we can only analyze what we have access to. And these are the limitations of each system we have, VSD, VAERS. So the way that these safety systems are built is to try to complement each other. And we understand the limitations of each and try to use the pros and the benefits that each one of those has, but understand the limitations that they have as well, so we're not blindsided, if that makes sense.
No, I fully understand, and that's why I think it's a point that's worth being made at this moment when we're looking at these statistics and we're saying that less than 5 per million doses causes anaphylactic shock. Then we know that, you know, what we've done is, what it appears to me, looks like we rolled out and first got the first responders, and so there's a lot of people that aren't following into the vaccine safety data link. So I know personally one person who's died, and I know personally one person who was airlifted. But that's from, again, it's from that drive-by clinic that comes. So that information isn't being counted. So I'm looking at the stats and I see them, but I can't think that there are not a lot more injuries.
So those people would not be captured, you are correct, but VAERS, unless they reported it, and they wouldn't be captured by VSD unless they were part of that system, but they would be captured by Vsaf, which is the new system that was put by the CDC. And so that's, again, how us knowing the limitations and the strength of each program helps us build new ones. And Vsaf was created specifically to monitor COVID vaccine side effects.
And so that means, and I just want to just share with you the complications of this. So we're saying every parent that I know is told to report to VAERS, but now we have Vsaf, so it just seems strange that HHS would create yet another program. You know, this is just the problem with actual recording of injuries, and I'm just going to leave that there. But it's, you know, there's many people who don't even know about VAERS. I know doctors are supposed to tell people, but doctors aren't even vaccinating these huge, you know, drive-by at the park or wherever. So I hear what you're saying, and I have a lot of concerns about the actual numbers that are being presented. But I also want to just, I won't say anything else on this issue because obviously it's a very important issue because I just see that there's a lot more injuries. But I just want to just bring up the fact that pregnant women were not included in the trials, and yet they're being encouraged to get vaccinated. And we're just saying that if they have an abort or a miscarriage or whatever, that's just normal. So I'm just going to make that statement and leave it there. I don't know if anybody else has any other questions.
Well, this is John, and I just wanted to have a chance to respond to a couple of your questions earlier. So one, your question about whether vaccines given at sort of non-traditional settings are being captured by VSD, the answer is yes, because you know, states have immunization information systems, also known as immunization registries. And so the expectation is that COVID vaccines that are administered in any location would be reported to those registries, and then all the VSD sites have data sharing agreements with their state immunization registries. So, you know, our expectation is that all or the vast majority of those doses will be communicated from the registries to the VSD sites. So we do anticipate capturing information about people who are vaccinated outside of the medical home. And then to your other question about underreporting in VAERS, underreporting is a recognized issue with VAERS because it is termed a passive surveillance system, or you know, reporting is you know, may not be 100%. But I think one piece of information that is perhaps informative that our office published a paper last year trying to better quantitate how often reporting for serious adverse events occurs. And so the two that we looked at were specifically Guillain-Barré syndrome and anaphylaxis. And so what we did was we actually compared the incidence rates from studies done in VSD and then looked at the reporting rates in VAERS. And so depending on the vaccine, and you know, we went back and looked at, like, you know, over 10 years worth of different published studies. So the reporting rates definitely vary by different vaccines, but I think one that's informative is during the the 2009 H1N1 pandemic, we found that the reporting rate of anaphylaxis following the H1N1 inactivated vaccine was about 76% of the incidence rate ascertained in VSD. So that gives us some sense that for serious adverse events such as anaphylaxis, we think the reporting rates are much better than the information you cited, which is referring to sort of non-serious adverse events that people may be less likely to report. And I think certainly with the media attention around the COVID vaccination and the anaphylaxis issue in particular, we think that there's certainly the probability that people are more likely to report severe, but again, we can't assume that it's 100%, and that's why we think it's important to monitor these things in multiple systems. I also just wanted to mention that the systems I discussed here today are the ones primarily managed by CDC, but there are other data sources being used through other federal agencies, for example, the Medicare database, persons age 65 and older, and then the VA healthcare system, and some other data sources. So these are not the only data sources being used for COVID vaccine safety assessment, but these are the primary ones being operated by CDC.
Thank you. Does anybody else have any questions? Okay, thank you, Dr. Duffy. I appreciate that. So now we'll move on, and I want to welcome Ms. Claire Schuster from the NIAID and the NIH to update us on the National Institute of Allergy and Infectious Diseases and National Institute of Health vaccine activities.
Great, thank you. Next slide, Annie. So while most of my talk today will focus on COVID-19, I wanted to start with a topic we've discussed at other ACCV meetings, vaccines to prevent sexually transmitted infections. With increasing concerns about drug resistance, it has gotten more difficult to treat STIs like gonorrhea. A vaccine to prevent gonorrhea would be an important public health advance. For background, in 2015, the FDA approved the Bexsero vaccine to prevent Group B meningitis. There is some evidence suggesting that vaccines for Group B meningitis might also protect against gonorrhea. For example, a study in New Zealand found that people vaccinated with Group B meningitis vaccine were less likely to contract gonorrhea. To further study possible cross-protection, in late 2020, NIAID launched a phase 2 clinical trial to evaluate if Bexsero can prevent gonococcal infection. The study is expected to enroll approximately 2,000 healthy adults. Next slide, please. This slide shows a snapshot of vaccine development timelines, beginning with when the microbial cause of disease were first identified. Starting at the top, you see it took over 100 years to develop a typhoid vaccine, and for COVID, vaccines were developed in 11 months' time. We'll talk a bit more about this on the next slide. This slide shows some of the COVID vaccines that are farthest along in development, and we've had some significant advances since our last meeting. Like our last speaker mentioned, the FDA has now authorized 3 of the vaccines for emergency use: Moderna, Pfizer-BioNTech, and Janssen or Johnson & Johnson. With the emergence of new SARS-CoV-2 variants, out of an abundance of caution, efforts are now underway to look at broadening protection from COVID vaccines, including evaluating next-generation and variant-specific vaccine candidates, should they be needed. For example, Moderna has developed a variant-specific vaccine candidate, mRNA-1273-351, against a variant known as B1351, first identified in South Africa. NIAID and Moderna will conduct a phase 1 study of this investigational vaccine among unvaccinated and not previously infected volunteers, as well as previously vaccinated adults. The study is expected to begin in mid-March. Next slide. And now a few updates on pediatric COVID vaccines. COVID-19 vaccine clinical trials in children are critical in order to develop safe and effective vaccines for kids to prevent disease, reduce transmission to others, and allow for safer interactions between children and their close contacts. Within the U.S., COVID vaccine trials have enrolled adolescents 12 years and up, and are expected to continue stepwise into younger age groups down to infants. Pfizer, BioNTech, and Moderna have completed enrollment in their studies of 12 to 17-year-olds, and initial results are expected in the coming months. On February 12th, AstraZeneca and the University of Oxford announced they would begin to test their vaccine in 300 children ages 6 to 17 in the UK. A child may require a different dose of the vaccine than an adult, and it is not uncommon to study half or quarter doses of vaccines in children. The immune response in children in different age groups and dose levels would be compared to older age groups and adults for which vaccines are readily available. If the results are found to be comparable in terms of the children's immune response to adult studies, that's a positive indication the vaccine is likely to work as well in younger age groups. Next slide. NIH has several efforts underway to better understand multisystem inflammatory syndrome in children, or MIS-C. For example, NIH has launched an observational study to evaluate the short and long-term health outcomes of SARS-CoV-2 in children, including MIS-C. The study, known as PRISM, will enroll at least 250 children and young adults ages 20 years or younger from diverse backgrounds across the U.S. NIH has also funded 8 additional projects to develop approaches for identifying children at high risk for MIS-C. The study will explore how a variety of factors, including genetics, influence the severity of COVID-19 in children and the chance of progression to MIS-C, along with other complications. The NIH awards will fund studies enrolling children with diverse backgrounds across 30 U.S. sites, Canada, the UK, and South America. Next slide. And a few updates about COVID-19 research pregnancy. A new NIH study will evaluate the effects of the antiviral remdesivir in pregnant patients who have been prescribed the drug to treat COVID-19. The study aims to determine how pregnant women metabolize remdesivir and whether there are any potential side effects. It will be conducted at 17 sites in the continental U.S. and Puerto Rico. In addition, studies are beginning to evaluate COVID-19 vaccines and pregnant women. For example, Pfizer and BioNTech recently announced a global phase 2-3 trial to evaluate their COVID-19 vaccine in approximately 4,000 healthy pregnant women. In addition, observational studies will look at COVID-19 vaccination and pregnancy, collecting data on immune response and any side effects among pregnant women who receive COVID-19 vaccine. Next slide. And now I'll share an update on research on treatments for COVID-19. An NIAID-supported study known as ACT2 found that a combination of baricitinib, an anti-inflammatory drug, and remdesivir reduced the time to recovery for people hospitalized with COVID-19. Patients who required high-flow oxygen or non-invasive ventilation during their hospitalization appeared to have the largest benefit. Their median time to recovery was shortened from 18 days to 10 days. The FDA approved baricitinib for emergency use last November. NIAID continues to study baricitinib as a treatment for COVID. The ACT4 study is looking at remdesivir and baricitinib compared to remdesivir and the corticosteroid dexamethasone among hospitalized COVID-19 patients. Next slide. And now I'll share a few updates from our NIH Director's blog from Dr. Francis Collins. Large numbers of patients who've been infected with SARS-CoV-2 continue to experience various symptoms long after they've recovered from the early stages of COVID-19. Often referred to as long COVID, these symptoms can include fatigue, shortness of breath, brain fog, sleep disorders, fevers, gastrointestinal symptoms, anxiety, and depression, and can persist for months. These effects are collectively referred to as post-acute sequelae of SARS-CoV-2 infection, or PASC. NIH has launched a new initiative to identify the causes of PASC and ultimately ways to prevent and treat these conditions. Next slide. I also wanted to let you know about a new resource developed by the Department of Health and Human Services called Combat COVID. This website contains information about clinical studies going on across the country and also information for how recovered COVID patients can donate blood plasma. For more information, please see combatcovid.hhs.gov. Next slide. Shortly after New Year's, we lost my uncle to COVID-19, just 5 days before he would have received his first dose of vaccine. After losing her grandfather to COVID last spring, 16-year-old artist Hannah Ernst began creating portraits of COVID victims like the one you see here of my uncle. To date, she has created over 1,000 portraits. I'd like to dedicate my talk today to my uncle and everyone we've lost to COVID-19. Thank you, and I'm happy to take any questions.
I just want to say I'm sorry for your loss. I was not aware.
Thank you, Barbara.
Thank you, Ms. Schuster. And again, yeah, I'm the same. I'm so sorry for your loss. Appreciate the presentation.
Thank you, Karen.
So now I want to welcome Commander Valerie Marshall, who will give us an update on the Center for Biologics Evaluation and Research and Food and Drug Administration vaccine activities. Welcome, Ms. Marshall.
Thank you. I'm going to go to the next slide. I will provide a very brief overview of the EUA process and discuss 3 vaccines that have since been authorized. On February 4, 2020, the Secretary of HHS determined that there is a public health emergency that has a significant potential to affect national security and the security of the United States citizens living abroad, and that involves the virus that causes COVID-19. On the basis of this determination, on March 27, 2020, the Secretary then declared that circumstances exist justifying the authorization of emergency use of drugs and biological products. These declarations were necessary to open a path for emergency use authorization. An emergency use authorization is a mechanism to facilitate the availability and use of medical countermeasures, including vaccines, during public health emergencies, such as the current COVID-19 pandemic. Under an EUA, the FDA may allow the use of an unapproved medical product to prevent serious or life-threatening diseases or conditions when certain statutory criteria have been met, including that there are no adequate, approved, and available alternatives. Once submitted, the FDA will evaluate an EUA request and determine whether the relevant statutory criteria are met and review the scientific evidence about the vaccine that is available to the FDA. The FDA, for an EUA to be issued for a vaccine, specific requirements must be met. These include adequate manufacturing information to ensure quality and consistency, that the vaccine benefits outweigh its risk based on data from at least one well-designed phase 3 clinical study that in a compelling manner demonstrates safety and efficacy. FDA expects vaccine manufacturers to include in their EUA requests plans for active follow-up for safety, including deaths, hospitalizations, and other serious or clinically significant adverse events among individuals who receive the vaccine under an EUA, to inform ongoing benefit-risk determinations to support emergency use authorizations. On this slide, I have presented 4 of those systems, including VAERS, VSD, BEST, and Medicare claims data. My colleague at the CDC has also discussed some of the monitoring mechanisms that are in place. The FDA has determined that the following vaccines have met the statutory criteria for issuance of an EUA. The totality of the available data provides clear evidence that these vaccines' known and potential benefits outweigh their known and potential risk, supporting the company's request for the vaccine's use in populations. In making these determinations, the FDA can assure the public and medical community that it has conducted a thorough evaluation of available safety, effectiveness, and manufacturing quality information. So since December 2020, the FDA has authorized 3 COVID-19 vaccines, including Pfizer, Moderna, and Janssen's COVID-19 vaccines. On February 22, 2021, the FDA updated its October 2020 guidance entitled Emergency Use Authorization for Vaccines to Prevent COVID-19. The updated guidance provides recommendations to vaccine developers, including those who have already received emergency use authorization for their COVID-19 vaccines and are seeking to amend their EUAs to address new variants. The guidance recommends that a determination of effectiveness be supported by data from clinical bridging studies comparing the immune response to the modified vaccine to that induced by the original vaccine for which efficacy data are available. Manufacturers are encouraged to study the modified vaccine in both naive individuals and in individuals previously vaccinated with the authorized vaccine. Additionally, the guidance outlines the FDA's recommendations for assessments of safety to support an EUA for a modified vaccine. On December 23, 2020, the FDA approved a supplement to the Biologics License application for cholera vaccine live oral to expand the usage to include children between the ages of 2 and less than 18. This vaccine was previously licensed for adults 18 to 64 years of age who are traveling to cholera-affected areas. These are just some FDA websites that provide more details and information on vaccine development in general, as well as the EUA process. This concludes my presentation. Thank you.
Thank you. Does anybody have any questions? Okay, thank you, Ms. Marshall.
Thank you.
I'd like to welcome Dr. David Kim with the Office of Infectious Disease and HIV/AIDS Policy to give us an update.
Well, thank you very much. First, I'd like to apologize for not correcting the date on the intro slide. This should obviously be March 4, 2021. Next slide, please. I'd like to take an opportunity for the next few minutes to provide brief updates on 3 specific topics that the Office of Infectious Disease and HIV/AIDS Policy, and specifically under the Division of Vaccines, have been actively engaged in and for this advisory committee to be informed of. The National Vaccine Advisory Committee is a federal advisory committee that provides advice to the Assistant Secretary for Health, who has been designated to manage the National Vaccine Program. So the National Vaccine Advisory Committee, NVAC, last met on February 4 and 5, and at that meeting, we heard updates from 2 subgroups that we have actively actively working on addressing issues in immunization. So Immunization Equity Subcommittee and the Vaccine Confidence Subcommittee, they've been at their respective work for well over a year, and they are almost prepared to submit their respective findings and recommendations. And we will be talking about the reports at the next meeting. At the meeting, the members also heard updates on the COVID-19 vaccine safety monitoring from CDC and the FDA. In the Advisory Committee on Immunization Practices, there is a COVID-19 vaccine safety technical subgroup that functions within the COVID-19 work group that provided current updates on the status of vaccine safety monitoring as the COVID-19 vaccine is rolled out. We also heard Vaccines National Strategic Plan 2021-2025, which I will be covering in the next slide. The next meeting for NVAC will be on June 16 and 17, 2021. Next slide, please. So the Vaccines National Strategic Plan 2021-2025, as the years would indicate, is a 5-year outlook on how on the immunization practices and research in the United States, and it's designed to be the roadmap for the immunization enterprise in the U.S. So the report, the plan itself, was released on January 19, and it is a latest incarnation of the National Vaccine Plan that was last published in 2010, and before that, in 1998, the original National Strategic Plan for Vaccines was released. So this is the latest update, and it is driven by the Interagency Vaccine Work Group that also functioned as the steering committee for the development of the plan. It incorporates interviews from 60+ vaccine experts, from immunology to public health to clinicians to the public. It also incorporates recommendations that were submitted by NVAC, and we underwent 2 rounds of public comments. First, for general solicitation for general public comments to inform the content of the plan, and later for inviting the public to comment on the draft Vaccine National Strategic Plan. The plan has 5 overarching goals. The first is vaccine innovation, both in terms of vaccine development and delivery mechanism. The second goal is on vaccine safety, and let me take a moment here to describe for you 3 specific objectives that we have for goal 2, which is to maintain high levels of vaccine safety. Objective 1 is to minimize preventable vaccine-related adverse events. Objective 2 is to improve the timely detection and assessment of vaccine safety signals and to inform public health policy and clinical practice. Objective 3 is to increase awareness, understanding, and usability of the vaccine safety system for providers, policymakers, and the public. The third goal is on vaccine confidence. The fourth goal is to improve access to vaccines, either as physical, financial, or other barriers to people getting vaccines. This goal addresses them. And the fifth goal is to promote global collaboration on immunization, meaning vaccine development and vaccine allocation and vaccine use. And currently, we are in the beginning stages of developing an implementation plan for the National Vaccine Plan. Excuse me. Next slide, please. And lastly, I would like to touch on the current status of the vaccine safety report. This is a report that aims to systematically review adverse events associated with routinely recommended vaccines. So it does not include safety issues related to the COVID vaccine, since last vaccine safety report that was released in 2014. To maintain independence and conflict of interest of the vaccine safety report, my office, which administers the National Vaccine Program, has commissioned the Agency for Healthcare Research and Quality, AHRQ, to conduct a systematic review and to write up the vaccine safety report. And it is in the final draft that is currently undergoing scrutiny and revision. And so the projected release is actually in the next several weeks. So we're getting very close to the end of releasing the vaccine safety report, which I have in the past promised that I would share with the members of this committee. That concludes my my updates from the Office of Infectious Disease and HIV/AIDS Policy. Thank you.
Thank you, Dr. Kim. Does anybody have any questions? I have I guess a question or a statement, Dr. Kim, and I'm very passionate about building the confidence of the stakeholder, and I think that's done, in my opinion, as a parent, is giving information and sharing information. Do you have any idea when you will have this information available? Because I'm hoping in June to talk about vac studies and really, looking at the information that you just shared.
I am sorry. I should have put the resource on that slide with the National Vaccine Plan. The plan itself is available for general consumption through vaccines.gov.
Okay, thank you. And yeah, I'm excited. I think, in the World Health Organization, I think it was 2019, they talked about the biggest concern was having the confidence stakeholder. And, in my opinion, that's done by just sharing all this information. So really appreciate this. Thank you.
I can't agree with you more. Thanks for your comment.
Okay, we're ready to move forward. I would like to open the meeting up for public comments. Do we have any public comments?
Thank you. If you have a public comment, please press *1 and record your name when prompted. I'm showing no public comments at this time.
Okay, thank you. Then I guess we'll move forward. Is there any future agenda items and or new business that anyone would like to discuss? Okay, and so I did have an agenda for March that we're going to postpone until June, and hopefully we'll have board members. I want to thank everybody for their presentations and their time. I understand how much time is involved in all this, but I'm still obviously very passionate about this. Let's see. Tamara, are we ready to adjourn the meeting?
Yep, we can have a motion to adjourn in a second, and yes.
Motion to adjourn.
Okay.
I second.
Karen. Yep, okay. All right, well, thank you, everyone, and thank you, Karen, for leading this meeting. We really appreciate it, and we'll see each other or have another meeting in June. Thank you.
Okay, thank you. Cheers.
All right, bye-bye.
Thank you.
Thank you all.
Bye.
All participants, this concludes today's conference. You may disconnect.